Stars with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. There is something for a future so bright.
Because our bodies, and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Cause the boys we always be fine.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில். மனதையும் உடலையும் பாதுகாப்பார். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் என்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை.
Because our bodies, and the future we hold. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. Hey, no.
Got you, bitch.
We are the stars, the bright and morning stars, with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies, and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. There is something for a future so bright.
Because our bodies, and the future we holding. We want for you to see that everybody can win. Could it be education or contraception? Cause the boys we always be fine.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில். மனதையும் உடலையும் பாதுகாப்பாய். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் இன்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை.
Because our bodies, and the future we hold. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family and we are planning to go around the world telling everyone that we demand
Welcome back to the second day of the International Conference on Family Planning's first ever virtual Not Without FP Forum. With over 5,000 attendees from around the globe, we are honored to host you virtually until we can once again convene together at our next ICFP to be held in Pattaya City in Thailand. Yesterday, we enjoyed scientific panels about innovations in family planning research and policy and advocacy during COVID-19, and how challenges in the delivery of family planning products and services were overcome. As well, the community sessions planned by the ICFP International Steering Committee's subcommittees featured in-depth discussions about how to craft and submit a high-quality abstract, the role of faith leaders in family planning and program implementation of high-impact practices in humanitarian settings. We learned about the importance of health services without financial hardship or barriers to access, the ways quantitative and qualitative data collection is helping us gauge the COVID-19 knowledge, attitudes, and practices around the world, and saw how various organizations are promoting innovative, evidence-based solutions to adapt to the challenges of COVID-19 in FP services, care delivery, demand generation, and advocacy. Finally, we determined that collaborative efforts within and amongst a variety of sectors is the most effective approach to tackling the challenges of today's new normal. And let's not forget yesterday's engaging closing plenary, Real Talk, Real Stories, Real FP, where our community members shared personal experiences with family planning access and care and how this has been affected by the pandemic. If you missed these compelling stories yesterday, don't worry. Make sure you are registered for the forum to be notified by email when the recordings of all sessions become available for your viewing pleasure. We are delighted to have you return for another day of sharing scientific research, challenges, and best practices regarding universal health coverage and the impacts of COVID-19 on family planning and sexual and reproductive health services. And once again, please don't forget to visit our co-hosts, sponsors, and partners in our virtual exhibition hall or join them at their side events. It has been exciting to watch the conversations unfold in the sessions, online and at the Not Without FP and individual ICFP community hashtags, which you can find on each session's page. Keep the conversation rolling. Without further ado, we will kick off today's morning plenary, UHC Data, Actions, Solutions. This plenary will break down the research and data behind successful universal health coverage schemes through the lens of family planning. We will discuss negative impacts of COVID-19 on family planning and SRHR services, the cost of unmet need for family planning, and solutions for successful UHC programs and effective COVID-19 response. It is my pleasure to introduce our moderator for this session, Peter Ngure, Policy and Advocacy Team Lead at Pathways Policy Institute and Fellow 120 Under 40 Next Generation of Family Planning Leaders winner. Peter, over to you.
Thank you so much, Dr. T, for the kind introduction. Welcome to the panel today on UHC Action, Solutions, and Data. I have a wonderful panel and a very powerful one of experts in reproductive health. And I will start off with Dr. Elizabeth Sully. Her research has focused on sexual reproductive health, including abortion, adolescent, and impacting on the cost of sexual reproductive health services. Dr. Sully is a principal investigator for a multi-year study evaluation on the impact of the gag rule. She has an MA in public affairs and a PhD in public affairs and demography. Dr. Sully is a member of the Population Association of America and the International Union of the Scientific Study of Population. Welcome, Dr. Elizabeth.
Hi, Peter. Thanks for having me today.
Dr. Philippe Anglewicz is a principal investigator of Performance Monitoring and Action, PMA, at the Bill and Melinda Gates Foundation, Bill and Melinda Gates Institute for Population and Reproductive Health, at Johns Hopkins University. He leads the development and realization of the PMA program research. He is an associate professor in the Department of Population, Family and Reproductive Health at Johns Hopkins University, and his areas of interest are family planning, reproductive health, migration, and service in developing countries. Welcome, Dr. Philip.
Thanks very much, Peter.
Kennedy Odede is the CEO and the founder of SHOFCO. SHOFCO is Shining Hope for Communities in Nairobi, in one of the largest slums in Africa called Kibra. SHOFCO has an integrated model of urban slum transformations and has been recognized for its community-based work, where it equips community members with tools to inform and guide the agenda of social transformations in Kenyan slums. SHOFCO has impacted more than 2.4 million slum dwellers during the COVID era, and SHOFCO has been recognized by Conrad and Hilton Humanitarian Prize as the world's largest humanitarian prize award to non-profits. Welcome, Kennedy.
Thank you, Peter, for having me.
Next, I would want to introduce Dr. Susan Mercado. Dr. Susan Mercado, as one of the panelists, is a medical doctor and a public health expert with extensive experience on international and national and local levels. She has extensive experience of more than 15 years in a distinguished career at the WHO as a director of non-communicable diseases and working in the life course approach. She has a lot of experience in tobacco control, health promotion, healthier cities, reproductive health, family planning, and health communication. She has worked in the Philippines as the undersecretary and also as a board member of the expert panel of public health at the Philippines Health Insurance Corporation. She is currently the director for food system and resilience at the Hawaii Institute of Public Health. Welcome, Dr. Susan.
Thank you very much, Peter, and good morning.
And finally, in our panel, we have Dr. Professor Unnop. Dr. Professor Unnop is the Chief of Family Planning and Reproductive Health in the Department of Obstetrics and Gynecology, Faculty of Medicine at the Chulalongkorn University in Bangkok, Thailand. He's also an Associate Dean of International Affairs of Faculty of Medicine and Secretary General of the Royal Thai College of Obstetricians and Gynaecologists. Dr. Unnop is currently serving in various boards, and since 2017, he is the Vice President of the Thai Menopause Society. He's also the President of the Thai Osteoporosis Foundation since 2020. Welcome, Dr. Unnop.
Hi, nice to see you.
So thank you. To help us dig deeper into this and to get more knowledge on UHC data, actions, and solutions, we'll have the first panelist, who is Dr. Elizabeth Sully, the Senior Research Scientist at Guttmacher Institute, talking to us about the potential impact of COVID on SRHR globally. Welcome, Dr. Elizabeth.
Thank you, Peter. Good morning, good afternoon, and good evening to everyone joining virtually today. I'm going to kick off our set of plenary presentations presenting on data on the potential impacts of COVID-19 on sexual and reproductive health in low and middle income countries. Before getting to the specific impacts of COVID, it's important to start off by recognizing the immense need that has existed for family planning services prior to this global pandemic. While modern contraceptive use has increased over time, as of 2019, it is estimated of the 1.6 billion women of reproductive age living in the 132 low and middle income countries, 218 million of them were wanting to avoid a pregnancy, but not using a modern method of contraception. Sexual and reproductive health care, including contraception, maternal and newborn care, and safe abortion care, are time-sensitive and essential services that cannot be put on hold during the COVID-19 crisis. Efforts are needed to maintain the current levels of care being provided, and our goal should be to not allow this pandemic to push back the important gains that have been made over the years. Prior to COVID-19, we were already seeing that failing to meet the sexual and reproductive health needs of all women in low and middle income countries was having a significant impact on people's health. The Adding It Up report from the Guttmacher Institute shows that if we were to meet the contraceptive needs of the 218 million women with an unmet need, it is estimated that there would be 76 million fewer unintended pregnancies annually, dropping from the current 111 million to 35 million each year. However, by failing to currently meet the already existing need prior to COVID, It means that there are 76 million avoidable unintended pregnancies, which in turn result in 26 million unsafe abortions in low and middle income countries annually. Any reductions from current levels of service coverage resulting from COVID-19 would result in people having a harder time preventing pregnancies. Pregnancies will become more complicated and dangerous, and abortions will become more unsafe. However, previous public health emergencies have shown us that the impact of an epidemic on sexual and reproductive health often goes unrecognized. And this is because the effects are not often the direct consequence of infection, but instead the indirect consequences of strained healthcare systems, disruptions in care, and redirected resources. To document the potential impacts that would occur if family planning and other sexual and reproductive health services were to be disrupted due to COVID-19, we compared the current levels of service coverage I presented data from just earlier to an illustrative scenario modeling a proportionate reduction in coverage of services for all low and middle income countries. Model-based estimates can play a really important role in these situations, where we can show the relationships between service changes and outcomes for people to make clear just what is at stake. This type of data can be particularly helpful for advocacy and for pushing for preventative efforts aimed at minimizing impact. So in April 2020, we published model-based estimates for all women of reproductive age and looked at the additional impacts we would see from a 10% proportionate decline in short and long-acting reversible contraceptive methods for all low and middle income countries. So for example, if 10% of women were using the pill, we looked at what the impact would be if this declined to 9%. This 10% proportionate decline was predicted at the time to be a modest scenario of impact and informed by declines that had been observed in the Ebola outbreak in West Africa. So we estimated that if we saw a 10% proportionate decline in short and long-acting reversible contraception, this would result in 49 million additional women with an unmet need in low and middle income countries and 15 million additional unintended pregnancies. We then updated this model in August of 2020, focusing specifically on the potential impacts of service disruptions on adolescents in low and middle income countries. By that time, other model-based estimates had come out, and we adjusted our scenario to take into account potential differential declines that we might see across specific contraceptive methods that Avenir Health and the United Nations Population Division had modeled. We therefore estimated method-specific declines, but the overall average proportionate decline in modern contraceptive use was 12%. So we estimated that an average proportionate decline of 12% in modern contraceptive use among adolescents in low and middle income countries would result in 2.1 million additional adolescents with an unmet need for modern methods and 734,000 additional unintended pregnancies among adolescents. It's important to note that these scenarios are of potential declines, and what is needed now is real data from people and from services on the impacts that are being observed, how this is varying across regions, across countries, and also over time as the pandemic has unfolded. It's possible that these impacts might actually be underestimates for regions or countries that have had stricter lockdowns or more severe outbreaks of the coronavirus. At the same time, they may be overestimates for countries that have managed to maintain essential sexual and reproductive health services during the pandemic, or in countries that have not experienced severe outbreaks yet, or may not at all. And as I believe we'll touch on later in this session together, there are also potential changes that may be occurring in demand for family planning services or for method switching, and we're not accounting for this in our modeling work. We have to realize that COVID-19 is not just a health crisis, it's an economic crisis. And we know that economic crises have important impacts on the fertility desires of men and women around the world. As we look ahead, the pandemic is forcing us to work differently, more collaboratively than ever before, and it's highlighting both weak points and opportunities for building stronger health systems in the future. An essential part of this involves ensuring that sexual and reproductive health is included as part of universal health coverage plans. The reality is, however, that with the COVID pandemic, resources are strained now more than ever, and decision-making around spending in health looks different. But the critical thing to continue to stress is that family planning has always been a smart investment, and an investment that can actually end up saving costs to the health systems. So we estimated that for every dollar that is invested in family planning beyond the current levels of care, we would actually end up saving $3 in the costs of maternal, newborn, and abortion care due to the reduction in unintended pregnancies. To break these cost estimates down a little bit further, We can see here in the first bar that current levels of care in low and middle income countries costs about $37.4 billion annually. If we were going to spend an additional $5.5 billion on contraceptive care to meet all needs in low and middle income countries, so that's going from $7 billion to $13 billion in the dark blue bars there, we would actually end up saving $16 billion to fully meet pregnancy-related and newborn care needs. This is through the prevention of unintended pregnancies. And overall, this would result in a net savings of $11 billion. So meeting the sexual and reproductive health needs represents an investment in the future, not a drain on the resources now. And this point is critical as we plan ahead for universal health coverage, and that family planning is simply a smart investment for us to be making even under an environment of more restrained resources than ever before. I want to briefly conclude by noting a few key policy actions that can be taken both in the short term as we respond to the immediate crisis of COVID-19, as well as in the longer term as we plan for how to financially and programmatically support the health and well-being of women globally. First, all sexual and reproductive health care needs need to be defined and promoted as essential services, including listing supplies on essential medicines lists, adopting innovative methods of care, and averting any loss in the gains that have been made in sexual and reproductive health, especially among marginalized groups. Looking past COVID, we need to build health systems that are robust and able to continue to provide care in future public health emergencies. This means including sexual and reproductive health as part of universal health coverage, exploring flexible and innovative funding approaches, and ensuring that the needs of marginalized groups, including adolescents, are being addressed. In both the short-term and long-term policy efforts, family planning is an integral part of an essential set of sexual and reproductive health services that all people have a right to. We do ourselves a collective good by recognizing and pushing for accountability on the full set of essential sexual and reproductive health services and rights versus siloed arguments or pitting funding for one service against another. In fact, it's only through recognizing the linkages between family planning and the other components of sexual and reproductive health care that we are able to highlight the financial benefits of this type of investment. Just want to conclude by thanking you all for the time, and I welcome and look forward to our questions and discussion together.
So thank you very much, Dr. Elizabeth, for such an elaborate presentation on the potential impact of COVID and SRH. Indeed, the cost of inaction globally has been seen, and the fact that essential services around family planning and the data available is not as much as we would want to have, especially in the country level, is a key component that my next presenter will be handling on. Dr. Phil will be talking about the impact and response to COVID, and especially with very specific to a few countries in Africa. Welcome, Dr.
Thank you very much, Peter. And very glad to have the opportunity to talk to all of you today about PMA's COVID-19 data collection experience, in which we captured the impact of and response to COVID-19 in some of the countries where PMA operates. And I think it's appropriate that this presentation follow Dr. Sully's, because I think this complements some of the themes that emerged from her presentation. Taking one step back and starting with some background about PMA, in the current phase of PMA, we initiated a new change in our study design, in which we transitioned from repeat cross-sectional study design to a longitudinal panel design with embedded cross-sections. So in this phase, PMA will follow the same women over time for 3 years and do 3 interviews, but still produce representative estimates of key family planning indicators for each of those years. This new phase started in late 2019 with our first set of 4 countries, Nigeria, DRC, Burkina Faso, and Kenya, when we conducted our baseline data collection around November 2019 through about January of 2020. So by February, data collection had not yet started in our second 4 countries, Uganda, Niger, India, and Cote d'Ivoire. And then we were forced to delay data collection when the COVID pandemic started to spread in the countries where PMA operates, and had to reconsider and take one step back about, well, what are we planning to do now? So we realized that COVID-19 presented a potential important opportunity for PMA, where we realized there was very limited survey data available on COVID-19, potentially rapid spread of the pandemic in countries where PMA operates, the need for information on the part of governments to respond to and address the pandemic, and the need for more information on the impact of COVID-19 on family planning, access to healthcare, and other key outcomes. So we decided to explore the possibility of a COVID-19 survey and repurpose existing resources towards this end. So our next step in this process was to discuss with our in-country personnel about next steps for this. So we liaised with our in-country PIs and other representatives from PMA and discussed, well, first of all, is this even possible to do under the pandemic circumstances, especially considering social distancing mandates that existed in many countries. We also wanted to know whether the information we collect would be used by governments and form inform their responses to COVID in their countries, and also what questions would be important to ask in the surveys. So after moving through this stage and finding that the information would certainly be worthwhile and used, we moved forward with creation of our survey instrument, where we ask basic knowledge, attitudes, practices questions about COVID-19, questions related to awareness of the pandemic, exposure to media messages, risk perception, behavior change, and then also a set of questions on the impact of COVID in socioeconomic status, as well as the impact on family planning, fertility, access to health services, and other outcomes related to family planning and reproductive health. After the instrument was created, we moved forward with training of our interviewers, who we call resident enumerators. And this posed a particular challenge for PMA because naturally most of our training is done in person, but that wasn't possible in many settings due to the social distancing restrictions that were imposed. And instead we had to transition to doing training virtually and move all of our materials to a virtual format, and then acquaint the in-country training teams with this new format. So after moving forward with this and successfully completing training, we moved on to data collection. So for data collection, our target samples were women who provided phone numbers in the baseline round of data collection that took place in each country in late 2019 or early 2020. Interviewers conducted interviews by phone, remotely, entered information on the smartphones through Open Data Kit or ODK. The target samples differed by country, were nationally representative in Kenya and Burkina Faso. In DRC, PMA data is representative of Kinshasa province. In Nigeria, Kano and Lagos states. So the data that we collected for this COVID-19 survey then I think proved to be an important, valuable resource for COVID-19 within each of these countries, because we could link the baseline data collected data collection that took place in late 2019 and early 2020 with this COVID data, thereby being able to look at change over time before and during COVID in certain outcomes of interest. And then also it it allowed the opportunity to reduce the number of questions that we had to ask in the COVID survey, because many of them we already had from the baseline survey that took place shortly before. So what did we find? First, I want to highlight some of the profound impacts that COVID-19 had on household economic status. So I'll start by looking at household income loss. So we measured household income loss by asking women who participated whether their household experienced a complete, partial, or no income loss as a result of COVID. And then the results here are presented in this figure on the left for Kinshasa, DRC, Kenya, Burkina Faso, and Lagos, Nigeria, moving from left to right along this figure. The blue color represents no income loss, orange represents partial income loss, and gray represents complete income loss. And we disaggregate this income loss by the wealth tertile that was measured at baseline. And by doing so, we're able to look at the question of whether it's households that had the lowest economic status to begin with that were the most vulnerable to income loss as a result of COVID. So overall, we found two key items from this area of research. First of all, we found that the income loss, as I mentioned, was profound across all settings. It was very few households, as we can see in the blue along the bottom, that experienced no income loss. The highest percentage experiencing no income loss was Burkina, ranging from 23 to 26% across tertile, and lowest was the lowest percent was in Lagos, Nigeria, at 6 or 7%. So the vast majority of households in all of our settings experienced at least complete or partial income loss as a result of COVID. Second of all, we don't find any evidence of a gradient in the income loss as a result of COVID across these settings, where there's not a significant difference in the percentage of households that experienced partial or complete income loss by baseline wealth tertile. So it doesn't appear that those households that were the lowest tertile at baseline were more vulnerable, with the exception of Lagos, Nigeria, where we do in fact find a gradient where the highest wealth tertile was least likely to experience complete income loss, followed by the middle and the lowest wealth tertile. Next, we looked at food insecurity and examined whether the impact of COVID on food insecurity might differ from overall household income. We measured food insecurity by asking women whether one household member went without food for an entire day since COVID restrictions began. And then the responses to this are depicted in the figure, similar to the previous one for Kinshasa, Kenya, Burkina Faso, and Lagos, where blue represents no food insecurity and orange represents food insecurity experienced by the household. So unlike income loss, we do find a gradient for food insecurity, where it's households that were in the lowest wealth tertile at baseline most likely to experience food insecurity compared to the middle and the highest. And this is true basically across all of our geographic areas. We also asked women whether this food insecurity was more common now than compared to COVID-19 restrictions, and the vast majority, 73%, reported that it in fact was. Then we looked at the impact of COVID on some family planning outcomes, starting with fertility intentions and the desire for more children, measured at the population level for Burkina, Kenya, DRC, Kinshasa, Nigeria, Lagos, and Nigeria, Kano. So we measured these fertility intentions as whether women wanted more children, with the responses being want no more children, want children but want to wait for 2 years, and want children within 2 years. And then we looked at the differences in these reports, these three categories between baseline and follow-up during COVID restrictions. So while you might expect to find that women wanted to delay or have no more children as a result of the COVID pandemic, in fact, we found the opposite in many settings, where we found declines in the proportion of women who stated they wanted no more children, and modest increases in the percentage of women who reported that they wanted a child but not for another 2+ years. And we found this in Burkina Faso, Kenya, and Lagos, where, for example, in Burkina, we can see here at the top that at baseline before COVID, 18% of women wanted no more children, which declined to 12% during COVID restrictions. We did not find any differences, significant differences between these two surveys in Kinshasa or Kano, but the other three settings we found fairly consistent results. Next, we looked at actual contraceptive use, and we compared just simple use or non-use between the baseline pre-COVID and the COVID survey that took place in June, roughly June of 2020. And we looked to see whether women were in any of these four categories. Either they never used consistently at baseline and follow-up, whether they continued the use of the same contraception at baseline and follow-up, or if their contraceptive use changed, either discontinuing or adopting a new method. So dividing up women into these four categories, we then looked at results for Burkina Faso and Kenya, where we found that the vast majority of women did not change their contraceptive use status during COVID-19. So the vast majority of women in both Kenya and Burkina Faso either continued not using or continued using the same method that they had. When they did change, either discontinuing or adopting, they were much more likely to adopt contraceptive use than to discontinue. So for example, in Burkina, the percentage that adopted contraceptive use during this period was 25% compared to only 6% that discontinued. And similar numbers for Kenya were 13% adopting and 5.3% discontinuing. So overall, we find some key and consistent results across PMA geographies. The impact of COVID-19 is profound across all households, regardless of wealth tertile and wealth level. But when you look at food insecurity, there's a gradient where populations that are the most vulnerable were also most affected in terms of food insecurity. Now, turning to family planning and fertility, again, one might expect that women would want to delay childbearing or not have children during the pandemic due to the environment and the uncertainty that the pandemic presented for the lives of women and households in sub-Saharan Africa. But in fact, we find the opposite. We find that fewer women wanted to have no children across several of our geographies. And we also found that an increase in women who wanted children within the next 2 years. There was also some suggestions that women might have struggles to accessing family planning services during the pandemic due to restrictions on health services during this time, as well as just general social mobility restrictions. But we found that it didn't appear, according to our results, that women had problems accessing family planning because they were more likely to adopt a method than they were to discontinue. So these are, of course, initial early findings. We continue to work on research in this area, and we look forward to future opportunities to present results that we'll collect from future rounds of data collection. So thank you very much. And if for more information, please see our website or Facebook, Twitter, or LinkedIn pages. Thank you.
Thank you very much, Dr. Phil, on that wonderful presentation on the impact and the response. Indeed, the conversations around household loss of income and the food insecurity are some of the effects that you have noted in the PMA studies go a long way into having this conversation where we can take it into a more grounded level. And my third presenter is Kennedy Odede from SHOFCO in Kenya, one of the slums in Kibra. And he will be looking into transforming urban poverty into an urban promise with the kind of data that you have presented. Welcome, Kennedy.
Thank you so much. First of all, I want to say greetings from Kenya. And I'm also so excited to be part of this international conference on family planning. So as you all know, I said before, I grew up in Kibera, and that was a really tough life. And this is because of my parents came from the rural area, migrating to what they call the city, as the city attract, and we ended up in this slum, whereby life was really hard. And just to open up again here is that we were 8 in a small, tiny room. So 8 children, and it was really tough for them to take care of 8 children. And this is why I really believe in family planning. You know what I mean? So it was a tough life. So that really forced me to be what I call a homeless kid or a street boy, eating from the garbage, and just knowing that you don't have a future, you don't have hope. So that's how my life was really, and knowing that you are born with this passport of poverty, and in a country that honestly is all about class, and really to break from this cycle of poverty is not easy. So I lost hope. But I want to share my story of hope a little bit on how we were able to overcome that. So I was searching the idea of change, seeing people dying because of lack of good health care, no jobs, hopelessness, and now I have this kind of a dream, although I was very informal. And one day I got an email of Jessica, who was coming to Kenya for study abroad programs. And we linked together, and she came to my community, and then we started working together. She was still a student, and I shared with Jessica my dream, that I have a big dream of what the people living in the slum are going through. I want to work with people in the community to transform their own life. And now we are just in Kibera with this SHOFCO. No proposal writing, nothing. It was just about passion. And I believe that change comes when people come together. Jessica joined the movement. It was amazing. We became very good friends, and just to open up, now we are married, I think almost 10 years ago, and we have children. But she was really, really one of the people who gave her brain in the beginning when we met. And the soccer ball for me is a symbol. Soccer ball for me is a symbol that you don't need anything complicated to solve a problem. What you need is that faith, is that hope, is the idea and the dream, and how to work on your dream to make it a reality. And for me, I believe that any change must, even if you're the best person in ideas, you must believe in people. People are the one who make things happen. And that's the idea of SHOFCO. Yeah. So SHOFCO was founded, as I said before, and then now we are in almost over 17 slums. And that's really important because that idea that started in Kibera has grown to over 17 slums in Kenya. And we have impacted over 3.4 million slum residents. And how do you do it? We believe in working with the local leaders. We look for other Kennedys who can be female or male in those communities, and we work with them to transform as we work in Madari slum, those kind of places. And we've seen the idea is how do we disrupt this survival mode, and fighting this inequality. And I believe that we can fight this historical change that perpetuates what is called the urban poverty. How do we turn it? So I've seen a lot of changes. So I say in Kenya, we have 47 counties, and here in Kisumu slum, for example, in Kisumu city, as I said before, Slums are being created by the city. The city is that kind of fake hope that attracts people. So you can see we are working in big cities. Kisumu, we work in a place called Nyalenda, Ubunga, Manyata. These are the slums that we're able to provide some services and work with the government. And also believe in work with the local government is very important for us to succeed. Nairobi, we are in Kawangware, Kibera, Mathare, Mkuru, Korokocho, many places. We're also in Mombasa and Kilifi County. And we have seen the growth. Right now, we have over 500,000 members through what I call SHOFCO Urban Network. These are a network of other organizations, of other women groups, youth groups in those areas who are coming together for what we call the transformation. Okay, so we work on 3 different areas that we call the transformation. Number 1 is physical well-being. And I said before, this is also about my story and the story of many millions of people who grew up in a slum. Well-being is very important. And it's so sad when you are not able to get that well-being, which is health in some ways. You know what I mean? You cannot be productive. And right now that I got education, I went abroad, I came back. I mean, just looking back, I saw people dying and I didn't understand why are they dying for. So right now I see, okay, there is cancer. We knew there's no cancer because growing up in something, you don't get tested to know what is really sick for because you are poor. You know what I mean? So it was really something that I really affected me so much, to see that we are not treated equally. We don't have enough healthcare for us. So that's important for me. Number 2 is opportunity. How do you get opportunity for the population? How do you give that hope? Whereby we have a school, I said that, school for girls, we work with women and girls. And then the 3rd one is I call the dignity and self-worth. It's all dignity. This I see dignity for me plays so well in family planning. When women are the one now taking the decisions, they owning it, it is their body. And they have their own right. So that's what I call dignity. So when a man really forces the wife in a slum to have many children, somebody is deciding for you. So we talk about dignity and also trying to make community really husband and wife partners to talk about their family. Can they really afford this? So that's why I say in 3 areas that we work in: physical well-being, opportunity, and dignity, which is self-worth. So, okay, we are now talking about what I call the universal healthcare access. As you know, I'm really sorry, there's a lot of privations on healthcare. I think for me, health is air. We have to be very careful with it. It really pains me when I walk in the slums and to see that they're getting the worst healthcare for them. So I believe what I call universal healthcare access. Human being, no matter you are rich or poor, or where you live, you should be able to have what's called healthcare access. For me, it's a dignity. For me, that is a human right. Because that for me is the foundation of everything. Without that, you can go to school. Without that, you cannot have a dream. Without that, you cannot be energetic. So, for example, SHOFCO operates 3 clinics, whereby one of them is in Kibera, another one is in Mathare, and 2 in Kibera, the big ones. And for example, we have reached over 100,000 patients with what I call affordable quality healthcare. That was in the year 2019. And malaria, Nairobi is not a malaria place, but people really travel and come in from rural area to Nairobi during Christmas or during holidays. So when they come back, we've seen almost over 3,000, almost 4,000 malaria rapid diagnosis tests and treatment. So there's some cases of that. And then what we do in our clinics also in our healthcare program is children. When you live in these kind of places, there is lack of nutrition. So we have screened over 17,000 children screened for malnutrition. And I can give you some good news is that mother-to-child HIV transmission at our clinics are 0. Amazing. Because of awareness, because of more campaign we've done. And compared to Kenya, which is 15% average in Kenya, so transmission to mother-to-child HIV is really 0. So I'm so happy for my team for that. And then in our clinics also, we have 98% HIV viral suppression for patients on long-term treatment. That's really working well. And then I want to talk about our partnership with the Challenge Initiative. That was really a powerful thing. because it really brings us it's bringing the Gates Foundation, brings the John Hopkins and the Ministry of Health in Starehe sub-county here in Nairobi. And I was very much touched with the impact of it. For example, over 4,000 patients now are enrolled with family planning. You know what I mean? And I talked about health before, is also that we need to work together. We need the government. That's why I believe so much in the challenge initiative, because it brings those partners. And it's also powerful because I feel most of the time informal clinics or faith-based clinics in the slums are really ignored. And yet, if you treat the search in Kenya here, they are I think they're almost over 60%. So government-run clinics are really less. So the government is assisted. So the idea that I love about this TCI is that it brings services beyond the government clinics. And the training that our manager Emma went through was just amazing. I just have to touch about that. Yes, so now we're in a very, very, very tough moment, which is called COVID. And I see in America, Europe, the vaccine is being rolled out. What about Africa? What about Kenya? What about other countries? So COVID honestly has proven something that we never really pay attention to: the inequality. The inequality that exists, the gap between the rich and the poor. When COVID was really announced, we were told very clearly, wash your hands, be in your house, stay away, isolation. But that was the words for the rich people who have lived in their apartments. You know, sometimes we forget about the poor. Sometimes we forget that some people don't live our life. So this became an issue. So Kibera and were like, hey, Kennedy, we are congested. We don't have even clean water, don't have even soap, don't have even food. Our life already been tough before COVID. So what are they talking about? We don't have a fridge to keep our food. You know, we have to survive. Anyway, so that was an eye-opener. Then I asked the team leaders, like, what do we do? So then they say we need basic need first. Based on basic need, everything is zero work. So that's when we start to bring clean water in the community. The second thing I did was to go to the government so that we can roll programs together, which really worked so well. And we were the first one, truth be told, to go on the ground, bringing in clean water to the community, and people feeling that, and empowering community health workers to feel that they can own this. You know, it's not about the rich anymore. If we die, you're gonna die. As you know, the slums were the place that was really most affected. Honestly, it was also to see the power of the community. They really were out. But we say that every neighbor will take care of each other. You know, it's high time for us to be together. And honestly, I saw the power. We reached many families. We were able to go door to door. We got partners to help us to train that. And then we're on the ground. And I was able also to give government advice. I got in the government committee, you know what I mean? So I was leading the informal settlement one, you know what I mean? So we were able to take ideas from the grassroots level to the government. It has really worked well. I get to know the Minister of Health very well, Mutahi Kagwe, through this work, for the man I admire so much. So it's really, really amazing for them also to recognize this power of the community. You can be the health expert, you know, to tell us to stay away from each other, but there's also reality on the ground. The people in the ground, how do they live? So we're able to have what I call comprehensive way of fighting COVID with the reality on the ground. Next, and I saw what I call it was all about trust. You know what I mean? Before I forget is this, as I say, I was impressed at the government work, but before that, these people were poor, they don't trust the government. So how do you tell them? There's more about information, misinformation. I remember I met a woman who told me, Kennedy, I better die from COVID than to die from hunger. And those was a very powerful thing. I mean, just to know that the reality of the ground is totally different. There's also a lot of misinformation that we really have to work hard to fight that. So that was really, I learned a lot from the community during this COVID, and we are still learning. So far, SHOFCO has reached, as I said before, 2.4 million people, and we are becoming the go-to government partner. We have been working well with the government. So, and SHOFCO also became what I call the disciplinary channel. Through our SAN network, we're able to work with the government on distribution channeling, So we also look forward that when the vaccine, which I'm glad we are in this conference, I don't want to see vaccine going for the rich people in my country. And I don't want to see vaccine going only to America and Europeans. No, we are all human beings. But there's something called Ubuntu spirit. I exist because of you. I'm there for you. So the point here is that if America can just accept their own people, or European and UK, my friends, you're doing zero work. We have to have a plan. What about the third world country? What about the Africa, the global South? That's when we know we have really proved. You know what I mean? And we can learn from HIV/AIDS. We can learn from other things from the past, whereby the poor countries have been left aside. For this COVID, nobody's safe unless we are all safe. So we are able to work on that well, and also we also realize that it's also about people need food. So we gave food to the community. We got partners like Give Directly. We were able to, Rockefeller came in and other partners, and MasterCard, so able to give people some cash through their phones and really build the local economy. So I was very impressed to see what can really happen when people come to together. So as we are working now, we are on the Christmas, so we don't know what will happen, but I think we might have another wave after this holiday. But I hope the solution is people have to have trust on the ground. If they are engaged and they feel there's dignity, I think there's nothing that is difficult for human beings. As I said before, COVID has shown us the power of urban communities, but has created major setbacks in health and development. And I want to tell the world that those who, as we, this COVID, I will not lie to you. Today we are talking about this conference about also family planning. My friends, we are behind. What do you think about those women who are going for their family planning shots? Clinics were closed. I saw really high increase of pregnancy for teenagers. So donors, government, partners, if you invested 50%, now you have to go to 99% in family planning because we have been set back. COVID was not only about COVID. It affected immunization, but it affected family planning so big. So I'm really worried as a community health worker, and organizer, that we are going to face a challenge post-COVID. So we need to invest a lot in family planning because it's tough. Clinics were closed. Where do you go to get your whatever? So it was really tough. So something that I want just the world to know that we have to really strategize again and go in full force. If we already have our setbacks, there's a high time to jump ahead and really come in full force. For us to have a healthy families, a healthy environment, we need to move again. Yes, so next is to say thank you so much for your time, everyone. I was able to learn a lot from my other speakers, and I'm just a community organizer, and I'm really happy to learn from my health experts in Kibera, in Mathare, where we work, and I'm happy to share with you what I've learned from them. Thank you so much.
So thank you very much, Kennedy, for the presentation. Indeed, having an impact of about 100,000 patients in your centers in Kenya and Mathare slums is really a phenomenal approach. And this kind of data is what is required so that leaders can be able to make decisions around reproductive health and family planning. And we are glad that the next panelist, Dr. Susan Mercado, will be discussing issues around data solutions and the actions that can be taken by different various levels of leadership. Welcome, Dr. Susan Mercado.
I'd like to greet everyone who has joined us today. I will be speaking about data solutions and actions. It's very interesting in our attempt to understand the current situation with the pandemic and to zero in on family planning. Data is such an important driver of our thinking and decisions on resource allocation, programs, planning, etc. However, when we get down to the typical health center or primary care provider who is providing services for women and girls, this is the sort of data that you will see. Data is unorganized. It's probably available, but it's not accessible. Now, I think the pandemic has caused data disruption. We've heard from the previous speakers about estimations on how the pandemic has and will impact on women and girls. And UNFPA has estimated 47 million women who may not be able to access modern contraceptives, 7 million unintended pregnancies, although our previous speaker talked about 15 million. COVID-19 will disrupt efforts to end child marriage, with potentially 13 million child marriages taking place between 2020 and 2030. This is based on UNFPA. But again, because of the inability to generate good data on the ground, we are mainly dealing with estimation. Now, it's a terrible time for an unwanted pregnancy. There is a lot that we don't know about COVID-19, but we do know that it has brought limited access to prenatal care, limited access to emergency obstetric care, higher risk for severe COVID-19 disease among pregnant women, and a possible risk for prematurity and low birth weight. The World Health Organization already flagged the risk among youth and adolescents, and our previous speakers have touched on the vulnerability of the adolescent or the teenage girl. The estimate is that there are 777,000 girls under 15 years who give birth every year in developing regions. Prior to COVID-19, 10 million unintended pregnancies among those 15 to 19 years old, and complications during pregnancy and childbirth are the leading cause of death for 15 to 19-year-old girls globally. COVID-19 has increased the vulnerability of young women and girls to unwanted pregnancy. 5.6 million abortions occur each year among adolescent girls. Adolescent mothers face higher risks of eclampsia, puerperal endometriitis, and systemic infections. And babies of adolescent mothers face higher risks of low birth weight, premature delivery, and severe neonatal conditions. Zooming into some of the data on the Philippines, and these are estimations based on trends that were culled from local reports. We have 1.7 million births per year. 200,000 births are among teenage girls. 40 to 50 Filipino girls aged 10 to 14 give birth every week. And a coronavirus baby boom with an additional 751,000 unintended pregnancies is expected if community quarantine measures continue until the end of the year. So it seems that the lockdowns is creating a lot of unintended pregnancies. Now let's move quickly into solutions. And the Philippines was one of the first countries to pass a law on universal healthcare. Universal healthcare, of course, provides all of us with the promise of better services overall, including family planning. And in this brief presentation, I hope to touch on some of the other aspects of universal healthcare. We have been talking about service delivery, but financing, information technology, and human resource investments are equally important parts of the conversation on family planning and universal healthcare. So for the Philippines, let's talk about financing for a moment. For the Philippines, multiple sources of funding for family planning is the current platform that's being used. Universal healthcare in the law expands the benefits of every Filipino and includes family planning. In 2012, the Philippine government allocated $67 million for the procurement of family planning commodities alone. So securing the resources for commodities is very important. And in 2017, the Philippine Health Insurance Corporation paid for $852,000 worth of services for family planning. Under the Universal Healthcare Law, local governments must invest in primary care, and that includes reproductive health and family planning through a special health fund that is consolidated at the level of the province and the city. The Philippines also passed, after many, many years and a very long battle, the first reproductive health law. It was called the Responsible Parenthood and Reproductive Health Law in 2012. The Philippines is the only Catholic country in the region, and there has been a very long standing battle between the church and the government on family planning, but a law was passed in 2012, And this is followed in 2017 by the Philippine Development Plan 2017 to 2022 that formally introduced family planning as a pivotal intervention in realizing the country's demographic dividend and also its sustainable development goals by 2030. So this is policy solution that is linked to universal healthcare. Now, actions that have been taken in relation to the universal healthcare bill, law, and the family planning or reproductive health law are zero co-payments and upgrading of public health facilities and increasing the number of service providers. The Philippine Health Insurance Corporation accredited 763 public hospitals and infirmaries. A maternal and child health package covered 3,243 providers that could be reimbursed for family planning services. And the coverage is 91% of cities and municipalities in the country. However, that coverage does not necessarily translate into universal access, but it is a start. Human resource investments are critical for family planning. It's one thing to say that we will provide financing for family planning, and it's quite another thing to have people on the ground who can provide quality care, particularly to adolescents. So the Department of Health of the Philippines actually deployed 1,424 family health associates who are licensed nurses tasked to provide assistance in the implementation and improving access and delivery of family planning services in areas with high unmet need. This is, of course, not enough in a population base of 110 million people, but it is a start and an example of the direction we need to take in terms of addressing the health system needs and requirements of family planning. President Duterte in 2017 issued an executive order entitled Attaining and Sustaining Zero Unmet Need for Modern Family Planning. Again, another breakthrough in policy and political commitment by the President of the Philippines. And this is something that sets the tone or the direction for local governments to accelerate their work on meeting the needs for family planning. There was a temporary restraining order by the Supreme Court on the Food and Drug Administration for the utilization of progestin subdermal implant supplies. And this was very controversial, but again, data is very important to overcome legal obstructions. And this has now been lifted in 2017, which improves access to one particular type of contraceptive. But this is just an example of how this journey is not a smooth one. And even if you have policies, you have resources, you have finances, there are obstacles that have to be overcome with the use of data. Now, one of the things that I was involved with and fighting for when I was working with the Philippine Health Insurance Corporation was to come up with universal electronic medical records. One patient, one record. Currently, as I showed you that first picture at the start of my presentation, many of the patients in the Philippines, many of the clients are still using records that are on paper, in folders, stacked on a shelf. So having reforms in the information system and having one patient having one record that can be accessed from any point or any place will be a very big boost to family planning, because this is a service that is continuous. It's not a one-shot deal. You have to keep on coming back. You need advice, you need support, you need services. So one patient, one record is something that is of critical importance. However, over the years, there's been resistance to reforms in the information system. It's probably because of complexity. There is weak infrastructure, poor interface design. So there may be electronic medical records in some private hospitals or some healthcare centers, but not all of them. There is user resistance among providers because it's cumbersome to sit down in front of a computer and to encode when you can just talk and someone takes down notes for you. There are issues about privacy compliance. There's not enough medical school orientation in the curriculum, and there's lack of public policy and support for universal electronic medical records. So the information systems are important for us to come up with good data, with good policy, and with good action. So just to summarize universal healthcare and family planning, we said we would talk about data, solutions, and action. And this is just to say that we often talk about family planning services. We talk sometimes about financing, but we do need to talk about the important role of technology and information systems in reaching every single woman or girl who needs family planning services. And we need to invest in human resources. This is a program that cannot move forward without enough people on the ground who can reach the people who are in need. Thank you very much.
Thank you very much, Dr. Susan, for such an elaborate presentation on data, and especially when you mentioned on the data and the responses and the legal framework that has been put in the Philippines, from the responsible parenthood law to other laws that are now active to ensure that issues around family planning are prioritized. And from that conversation, we see that everything falls on leadership. And our next panelist is Professor Unnop, who will be discussing to us about leadership and health systems and giving us examples of the success that have been had through good leadership in Thailand. Welcome, Professor.
Thank you. Hi, everyone. Thank you for giving me an opportunity to join this session. As you may be aware, Thailand has a great success in family planning during the past 5 to 6 decades and has been used in many occasions as a case study of successful family planning program. And Thailand also has a success in fighting against the COVID-19 pandemic during the first wave in early last year. And although the success of these two efforts happened almost half a century apart, they share some similar key success factors, which include leadership and health system. In 1950 and 1960, Thailand was a predominantly rural society where women had more than 6 children per family on average, and no family planning services were provided by government at that time. And the population growth rate at that time was very high, as 3% per year. And if nothing has been done to slow down this excessively high population growth rate, bad effect to the economy, development, and society would happen. And Thailand, we were fortunate that at that time, the Thai government listened to the warning of this population problem from many international and national organizations, and with a strong support from key academics and health officials. Finally, the first official population policy was established in Thailand in 1970, together with the launch of the National Family Planning Program in the same year. Let me show you this historic photo of which we are very proud. Our late King Rama IX visited the first family planning clinic in Thailand at my hospital, Chulalongkorn University Medical School, in 1965, the same year that our clinic was opened. And after that, doctors and nurses from provincial hospitals throughout the country attended short training course in family planning, then went back to their hometown to open the family planning clinics in all parts of the country. Our family planning program in Thailand had many innovative approaches, such as a slogan, the more children, the poorer, and the very popular, stop at 2. It means stop at 2 kids. And this photo has been taken from Chulalongkorn University Family Planning Clinic. And you can see women from provincial outside Bangkok waiting to receive services at our family planning clinic. And this showed that the demand at the time was very high. And in places where community health facilities for family planning were underserved, an innovative mobile IUD team was sent to help providing services there. And you can see a lot of people waiting to receive the service from our mobile IUD team at that time. Since we have limited time, it's not possible for me to show you all the details of our family planning program. In sum, factors contributing to a success in family planning program in Thailand include a strong leadership. Strong leadership means the national policy supported by the Prime Minister and the Cabinet, and the cooperation between all related stakeholders. Although the Ministry of Public Health has taken a leading role in National Family Planning Program, cooperation with other parties, other organizations, NGOs and government organizations was very important to support the implementation of the program. Other key success factors include the basic healthcare infrastructure. Thailand, we have a very strong basic healthcare infrastructure, the PHC or primary healthcare program, and UHC is universal health coverage in Thailand. I mean, these two platforms has played a major role in maintaining the success of our family planning program. Another important reason for the success was the flexibility and innovativeness of our program. New methods at that time were introduced, including Depo-Provera and mini laparotomy tubal resection, the new way of delivery methods, the postpartum program, the task shifting the nurses and midwives providing family planning services, and the new ways of distributing contraceptives, including community-based distribution, the free contraceptive distribution. And the very important is the role of the private and commercial operations. Many NGOs devoted to family planning have been established at that time, such as PPA and PDA in Thailand. From 1965 to 2020, the TFR in Thailand has went down a lot, from above 6 to 2 in only 2 decades. And at the moment, our TFR is 1.5, which is very low. The population growth rate in Thailand has been lower as well, from 3 in 1970 to 2 in only 10 years. And now it is 0.2, which is too low for our country and cause a lot of problem, including the shortage of workers in our country. And Thailand is a paradise for contraception, and people who live in Thailand can have an access to family planning services and contraceptives services everywhere. And at the moment, the CPR or contraceptive prevalence rate in Thailand is close to 80% now. As mentioned earlier, the success of family planning in our country has been maintained by a very good or very strong basic healthcare structure in our country. First is the primary healthcare in Thailand, which has been developed since 1970s. And the PHC in Thailand emphasized the community participation, appropriate technology, basic health service, and intersectoral collaboration. And this slide shows you the importance of the primary healthcare in our country. Not only the government healthcare officers who provide the primary healthcare service in the grassroots level, but the people who live in the community play a big role in primary healthcare. We have 1 million of village health communicators and village health volunteers recruited from the villagers in that community and trained, and then help providing education, advocacy, and basic healthcare services, including family planning. This is very important to maintain the success of family planning in our country. This slide shows a timeline of the health system development in Thailand. And we have the UHC established in 2002. At the beginning of the UHC, we faced a lot of challenges, but we have passed that challenge. And at the moment, the achievement in the UHC has been shown in our country. Apart from a comprehensive benefit package provided or covered by the UHC in our country. The family planning services, including LARCs, have been included in the benefit package of our UHC as well. And this is also another important factor to maintain the success of our family planning. And let me move to the next slide, which will be related to the COVID-19, the threat for a global society at the moment. Thailand was the first country outside China to detect a case of COVID-19 in early January last year, and followed by a gradual increase of new cases in January and February last year. But before a rapid increase of cases in March, the government of Thailand at that time escalated the response from the ministry level to national level. And after a big effort of the people in the country of Thailand, in early May, the curve of COVID in Thailand was flattened with limited local spread, as shown in this slide. So a key factor for success in the management of COVID pandemic in Thailand includes, first is the strong leadership, which share some similarity with the family planning program in Thailand. We have a very strong leadership. We have a whole of government approach. We have what they call the CCSA, or Center for COVID-19 Situation Administration, which is chaired by the Prime Minister. And this is a single command center to fight against the pandemic. And another important factor is the whole of society approach, included the active engagement with academia and the private sector. Other important factors contributing the success of COVID-19 in Thailand include the strong health facilities. This is the same factor at what we have done during the family planning program. And we have a very strong universal health coverage, and we also have a very strong primary health care program. The village health volunteers, like 1 million of these people who conducted door-to-door visit for health education, for active case finding, and also disease surveillance and quarantine measure, and even distribute a face mask to the people in the village. And all these, contribute to the success of the fighting against pandemic in Thailand. World Health Organization Director has singled out Thailand as an excellent example in fighting the coronavirus later last year. Unfortunately, the story has not ended yet. We now have a second wave, which is bigger than the first one. And due to a very successful family planning program and low population growth in Thailand, Thailand is short of workers and need to import foreign workers, particularly from our neighboring countries such as Myanmar. And not only the labor, but also the disease or COVID-19 comes with these migrant workers and cause a new wave of pandemic in our country now. And most of the cases in the new outbreak in Thailand are linked to the migrant workers in an industrial province near Bangkok. And hopefully we can pass through this challenge using the same ways that will prove to be successful for family planning program and the first wave of pandemic in Thailand. Thank you.
Thanks so much, Dr. Unnop, for such an elaborate presentation. Indeed, we are delighted to see that there are countries where leaders, including presidents, are taking family planning seriously and impacting on the laws. And would you, from your presentation, elaborate further on family planning and reproductive health services in Thailand, especially during COVID? We have heard much about it before COVID. What has been the impact during COVID, and what responses has the government taken?
Thank you for your question. We are lucky in Thailand. We don't have a very big wave of the COVID-19 last year, just only like 2 months of lockdown in our country. Although we don't have much effect of the COVID-19 for reproductive health and family planning in our country, we do have plan for reproductive health services and family planning in our country. We have launched a guideline for the healthcare workers how to provide family planning services during the COVID-19 pandemic, where people cannot come to the facilities. We also make use of the telemedicine, and we also make use of the community health workers providing services at the doorstep. But we don't have much of the problem at the moment because, as mentioned in my talk, Thailand is a paradise for family planning and contraception. You can find everywhere. For the oral contraceptive pills, you don't need a prescription. You can go to the pharmacy near your residence and buy a pack of pills anytime.
Thanks, Dr. Unnop. Indeed, it is very interesting to hear how easily accessible for family planning it is in Thailand. And so we go back to Dr. Elizabeth, and following on the same conversation, Dr. Elizabeth, you talked about the cost saving that can help make the case for including family planning and SRH in UHC essential package lists. Kindly elaborate on what do we need for us to have effective budget advocacy in providing these services?
Thanks for that question, Peter. I think there's a few different components of what we need to think about in how we budget for family planning as part of universal health coverage. The first I touched on a fair bit in the presentation, which is that we can't really take a siloed approach to thinking about family planning. If we cost family planning in that way, then we're not actually going to accurately cost for the full package of sexual and reproductive health services. So we really need to take into account the synergies that are occurring across different interventions to understand the cost of a package of services and what it means to provide that as a package. The second piece is we need reliable data on direct costs because we need budgeting to be responsible and accurate. We recently published a piece in Sexual and Reproductive Health Matters that provides for over 100 sexual and reproductive health interventions direct costs at the country level. And I think these are critical building blocks that we need to ensure that accurate budgeting is taking place. The third piece, I think, is that we really, and Dr. Mercado touched on this in her presentation, is we need to think about the health systems costs. She really highlighted the human resources and the investments that need to be made there and the trainings that need to happen. But I think there's a larger range of programs and systems that we need to make sure are being properly supported. So we can't think about universal health coverage as just coverage, that we also need to think about how the quality of that care that's being provided, how and where it's being delivered, and what services are actually being offered. We recently, colleagues of mine at the Guttmacher Institute recently did an analysis of post-abortion care service provision in 10 countries and that covered the 3 major developing regions. And they found in 9 out of 10 of those countries, less than half of the facilities could provide just the basic levels of post-abortion care. And so this is a mandatory service that's supposed to be provided in all of these facilities, but the capacity of these facilities to meet those standards really need to be addressed. So I think we have to think not only about sort of what it costs to provide those services and what services are being covered, but are we properly, building up the human resources, providing the technical capacity, the commodities, everything that's required to ensure that those services are being provided and provided at a high level of quality as well. So I think we need to sort of look at that holistic package there.
Thanks, Dr. Elizabeth, for that response. And I think it ties a lot to the presentation by Dr. Mercado on technology. And so I would want to hear a comment from Dr. Mercado on how use of technology for family planning communication to vulnerable groups, including the young, the persons with disability, women, how it has had its impact and how it has been successful. Dr. Mercado.
I think, Peter, one of the realizations of the COVID era is that we need to be connected through technology. And internet connectivity is not universal. In fact, it's a great divide. And in fact, a lot of people are not able to access any kind of healthcare service simply because there is no connectivity. And those are huge investments that need to be made by governments. These are not things that can be done at the grassroots level. you need to have good information technology infrastructure in order to be able to engage with everybody, whether it's through their phones or through computers or through mainstream media. But the internet and the infrastructure for connectivity is of critical importance. Because of the limitations and restrictions in movement of people, we have found, and this is what we're doing right now, that we can continue to work, we can continue to advocate, we can continue to look for solutions. But if people are not connected through information technology, we have nothing. So I think this is a most important consideration for universal health coverage, like human resources. They're kind of like the invisible pillars that will make universal healthcare work.
So with the conversation of use of technology and the way Dr. Mercado has talked about the limited use of technology and internet globally, Dr. Phil, your PMA 2020 survey was administered using phones. Do you have any concerns on the response bias, especially because you selected women and one of the issues was characteristics on the phone ownership that they had and coverage? Would you mind to comment around the bias that could have been there during the study?
Thanks very much for the question, Peter. And it's certainly a good question. When we decided to depart from our traditional approach of interviewing women face-to-face and move to a phone, we were certainly concerned about the potential impact of this change in mode on biases as well as responses to the survey. And we wanted the data, of course. It was important for the data we collected to be representative of the geographies in which we work. So we took some steps in advance to try to increase response rates and reduce any type of bias. So some of the steps we took is collecting, number of phone numbers for each woman who was in the survey to provide different ways of contacting them. And then also matching the same interviewer at baseline with the phone survey so that there was some familiarity there, which would, we think, lead to better quality responses and a greater likelihood of actually connecting with the respondent. So thankfully, pleased to report that our response rates were high across all geographies, where we had a relatively large percentage of women who provided phone numbers to us. And of those, we were able to successfully contact a high percentage of women who did own phones. So we weren't overly concerned about bias, although in Kano State, there was less of a successful response rate than in other environments. However, that we felt wasn't enough in itself just to address the potential bias. So we also used an approach called inverse probability weighting, where we looked at the characteristics of those who answered the baseline survey, which is face-to-face, with the phone survey, and then corrected for any potential bias or systematic difference in those characteristics by using this additional weighting approach. So we feel like with these approaches, we're able to ensure that the data we collected is representative of the overall population and relatively free of any biases for the phone survey compared to the general population. Thanks.
So thanks, Dr. Phil, on that. And finally, as we finalize on the issue of technology, Dr. Mercado, you mentioned that electronic medical records are really becoming impactful in getting data on family planning. What would be the key challenges to electronic medical records for family planning coverage?
I think I'll still circle back to the issue of connectivity, that governments need to invest in connectivity, and connectivity is going to be one of the, one of the anchors that will save us during this pandemic. So we tend to think that there is connectivity for everyone, but that is not true. And that inequity created by the lack of universal connectivity is going to be our greatest obstacle to reaching everyone in the context of universal healthcare.
Thanks so much, Dr. Mercado, on the issues of medical records. And looking at the long-term issues around health, I would want to pose this question to Kennedy. How has COVID affected long-term health and family planning outcomes in the slums where you work, knowing the limitations that are there technologically, population-wise, and all the other limitations that you have? Have there been long-term effects to health and family planning outcomes?
Yeah, it's necessary. The community, first of all, is about trust. I mean, so if you talk about informal settlement, it's a place that people come from different ethnic communities come together. It's all about survival mode. So they're coming there. So, and most of the time, people really, government or other big organization ignore them. I mean, so the important part is that you need to work with them, you know, because the idea is that I feel like we are trying to solve their problems. I think they live it. They understand it better. And they have proven to us during COVID, you know, how they could come together as a community to fight this COVID, you know. So I think we have to really put a lot of emphasis as you work in these urban centers to the community is the most important thing. You cannot succeed without working with the locals in that area. Thank you.
Thanks very much, Kennedy, for that. Indeed, the long-term effects of COVID, especially in urban slums, are really a big deal. And to delve further into this, I would want Dr. Elizabeth to continue responding now that we have a vaccine that is available. How do these long-term effects get sorted? How do we begin as a society to build back and address the potential negative impacts that may have occurred on family planning and other SRH services in our communities? Dr. Elizabeth?
Thanks for that question, Peter. I think that how we build back after COVID represents a real opportunity to think about how we're providing services and what services are being offered. We talk about building back better, and I think by definition that means building back better means we're not building back the same. And so I think there's a lot of great ideas actually that have come out from a number of the speakers in this presentation that we should be thinking about ways to apply them across different contexts. So Professor Unnop was talking about telemedicine being a key component of that. And so we need to think about what are these innovative models of service delivery and ways of scaling up things like telemedicine and self-care interventions, and how do we remove barriers that are in place in many places? So prescriptions to access contraceptive pills, and Professor Unnop mentioned that as part of the success in Thailand was removing those barriers. And so I think what we need to be doing is learning across contexts and looking at these success stories and seeing this is the moment to think about how we might have the political will and opportunity to start to remove some of those barriers or explore scaling up these different methods of service delivery. Though I thought there was a really important point in Dr. Mercado's comments about the role of connectivity and internet, and that not everyone has access to the internet. And so I think part of our building back better also needs to take into account the ways that inequities could be further exacerbated. So if we pursue telemedicine, but without a lens towards inequities, then we're only going to further exacerbate the people who are already being left behind by services. And so I think our approach to building back better needs to have ingrained in it from the start a central focus on addressing the inequities that existed before COVID, that are being exacerbated by COVID, and we need to make sure are not being further exacerbated by pursuit of different approaches to providing care in a build back better approach.
So thanks, Dr. Elizabeth, for that. Indeed, we need to build back better for our communities. And we have data from PMA that was collected in June, July, and now we will be realizing new data in the short term. Dr. Phil, do you feel that the data collected between June and July because of COVID represents the real picture, or will this change over time?
Absolutely. Thanks for the question, Peter. I think it's highly likely that the relationship between COVID and the impacts of COVID on various outcomes related to economic status and family planning and fertility is certainly going to change over time, and in ways that I think are going to be difficult to predict. So I think as we think over time, certainly women's supplies and facility supplies of contraceptives may run out depending on the stock that countries have in place at the time and that women have in place at the time. So we could certainly see more women and more suppliers run out of contraceptives in some environments. There's also potential for continued great economic impact on households and individuals. And while we certainly saw evidence of that at the early stages of the epidemic, the impact could be even greater as time goes on, and it certainly could vary across settings. Then I think it's also important to note that some outcomes that we measured in our COVID survey are probably better measured a longer period out into the pandemic. So for example, pregnancy, it's really not ideal for us to measure pregnancy at such a short period of time after COVID restrictions were put in place, and certainly better for us to measure it over a longer period of time. So you know, in all of these changes, I think it certainly impact family planning and fertility related outcomes, where I could easily see women changing their minds later in the pandemic and wanting to postpone having children in a way that we didn't see maybe earlier on in our data. And we could also easily see more discontinuation of contraception further on into the epidemic than we have seen so far with our data. So fortunately, we've included COVID measures in our most recent surveys as well, which took place in these same countries at the same time as the first round between November and January of November 2020 and January of this year. So we can look at these longer term impacts of COVID on outcomes of interest. Thank you.
When the pandemic started, I don't think family planning was a top of mind concern for countries, for communities, for healthcare organizations. But as we sit here today, it seems like this is one of the problems and one of the solutions for the pandemic. So I think I'd like to hear from the others, what are the key things we need to do to move this forward on the global agenda?
Thanks, Dr. Mercado. Maybe we can start with Dr. Phil, then go to Elizabeth, and then listen to Unnop.
Thanks. I think that's a great question, Dr. Mercado. And, you know, given my position and what PMA does, I think naturally my response is going to be data. I think what we saw in sub-Saharan Africa is likely true elsewhere, where collecting data that's representative and important is quite a challenge under COVID. But yet these data is really necessary in order to direct COVID-related efforts related to, you know, the impact of family planning, as well as the responses to COVID on the part of affected populations. So, I mean, I still think that there's not as much data out there as there should be, because this is what will provide guidance to responses to COVID related to family planning. So for me, I think continued data collection is one of the critical needs.
Thanks, Dr. Elizabeth.
Yeah, I would completely concur with everything Phil said. And I think also then taking that data and really trying to link it to differences in policies that have been implemented across countries. I think there's been some interesting data released by MSI Reproductive Choices that show that some of the countries that had the worst declines in services were those that imposed strict lockdowns, that didn't, when they imposed those lockdowns, find ways to ensure that essential services were still being maintained and didn't think of family planning as an essential service. And so I think collecting data alongside under like some of this policy variation that's been across countries is really important for highlighting the ways in which when family planning isn't being incorporated into an emergency response plan, that we're going to have these massive unintended consequences. But when it is, we can avert those and we can mitigate it. And so I think it's collecting data, and it's collecting data tied to policy, and then also understanding, you know, Phil presented some great data showing where impacts weren't as large as we thought they might have been. And I think then trying to understand and find more data on why, what were the mitigation efforts, what happened to try to prevent that, so we can really get that full contextual picture, so we know in a future public health emergency sort of what are the right responses, what should our programmatic planning be for that.
Thanks, Dr. Elizabeth. Professor Unnop?
In my opinion, it is very important for the leader or the policymaker in the country to have a commitment to fight against, these challenges, and listen to academics and the health officers. And it is the duty of us as the academicians and the health officers to provide scientific evidence to the policymaker and try to convince them, and transform these into policy and action. I think this is the most important thing in my experience. Thank you.
Thank you very much, my wonderful panel. Indeed, the conversation has been great about UHC, data, action, and solutions. Thank you, Dr. Elizabeth. Thank you, Dr. Phil. Thank you, Kennedy. Thank you, Dr. Mercado. And thank you, Dr. Unnop. Indeed, the impact of COVID on UHC and on family planning has been profound. And we require stronger responses, especially from our leadership, because the data is now available and all we need is proper leadership in our health systems. We know UHC will not be achieved without family planning. Thank you so much for the conversations, and enjoy the rest of the conference. Thank you and have a good day.
Wow, thank you so much, Peter, and all of our panelists for sharing your insights with the community. As Dr. Unnop noted, people must share their collaborative activities through healthcare service, appoint themselves as owners of communities' problems, and share their solutions to those problems. We hope you will attend today's community sessions from the perspective of problem solvers to bring the best practices we learn here today into your own work. After all, to succeed, we must innovate and collaborate in order to accelerate progress. Next, you may jump into a variety of community sessions organized by ICFP's subcommittees focused on the private sector, advocacy and accountability, the demographic dividend, youth, humanitarian and crisis settings, and the implementation of best practices. Plus, don't miss our exciting closing plenary, cementing the connection between FP and UHC, where we will hear from inspiring keynote speakers and witness two special performers as they lend their voices to the family planning community. I'll see you again at the closing plenary in approximately 3 hours' time.